Diabetes mellitus in pregnancy includes individuals known to be diabetic prior to pregnancy, and also those who develop impaired glucose tolerance during pregnancy. Gestational diabetes refers to impaired glucose tolerance of any degree that develops or is first recognized during the current pregnancy, irrespective of whether it resolves after delivery or not. Diabetes is associated with poor health outcomes for a mother and her baby if not properly managed. Many patients with gestational diabetes are asymptomatic, making screening for all pregnant women mandatory to identify those at risk. The fasting blood glucose test must be done on all pregnant women at booking and also at 28 to 32 weeks. The management of diabetes mellitus in pregnancy and the puerperium involves close monitoring of the woman by a multidisciplinary approach comprising a team of obstetricians and midwives, nurses like dietitians and physicians, anesthetists, and pediatricians. Labor, whether induced or spontaneous, and cesarean section are best supervised in the hospital under specialist care. Anti-diabetic treatment requirements reduce dramatically after delivery. Hence, post-delivery treatment doses must be tailored to each individual patient's needs. A newborn baby of a diabetic mother needs specialist care and is best managed by a pediatrician or neonatologist. Hypoglycemia in a baby in the first few hours of birth is a major problem, and it can be prevented by initiating early, as within 1 hour breastfeeding, to initiate breastfeeding early. And they may also require management for respiratory distress syndrome, electrolyte imbalances, for example, hypercalcemia, hypokalemia, hypomagnesemia, and hyperbilirubinemia. So all diabetic mothers must be cancelled on family planning. Causes: pre-existing type 1 diabetes mellitus and pre-existing type 2 diabetes mellitus and gestational diabetes mellitus. The symptoms are a previous history of large babies, usually above 4 kilograms, previous poor obstetric history like fetal deaths and miscarriages, among others. And other features of diabetes, usually is the condition is asymptomatic. The signs that are usually listed are fetus larger than gestational age, as assessed by serial symphysiofundal height or by ultrasound scan. Also, fetus smaller than gestational age, that's IUGR, and presence of polyhydramnios and other signs of diabetic complications. So investigations, all basic antenatal care investigations, also ultrasound scan, fetal anomaly scan at 16 to 22 weeks, and serial scans for growth assessment in third trimester. Urine culture insensitivity, that's done monthly. High vaginal swab for candidiasis. Blood urea, electrolytes, and creatinine. Blood glucose profile, as fasting blood glucose and 2-hour postprandial blood glucose monthly in the lab, more frequently by self-monitoring. Finally, glycated hemoglobin, that's HbA1c, every 6 to 8 weeks. There is no place for urine glucose estimation in the management of diabetes in pregnancy except for screening, and self-monitoring of blood sugar should be encouraged for those who can afford a glucose meter. The main treatment objectives are to achieve normal blood glucose and glycated hemoglobin levels throughout pregnancy, labor, and delivery and puerperium, to prevent maternal and fetal complications, to prevent neonatal morbidity and mortality, and to detect and manage other associated complications, for example, preeclampsia. Non-pharmacological treatment. So general measures like dietary modification, exercise, patient counseling, and education. Blood glucose monitoring must be discussed with a dietitian, obstetrician, or midwife, respectively. The frequent antenatal care visits are required. And for delivery by 40 weeks gestation, patients should be well controlled with no complications. So delivery must be ensured by 40 weeks gestation in well controlled patients with no complications, and also by 28 weeks gestation in insulin treated patients and those with complications. A cesarean section for patients with either of the following: that's severe preeclampsia and previous cesarean section, and also advanced maternal age and malpresentation or fetal macrosomia. If elective preterm delivery is necessary, mature the fetal lungs with corticosteroids under specialist care. Preparium, so close blood glucose monitoring in the first 48 hours after delivery should be done. With pharmacological treatment, let's look at some notes on glycemic control in diabetes in pregnancy. So before planned pregnancy, optimize glycemic control. So optimize glycemic control in non-diabetics before pregnancy. During pregnancy, if diet alone cannot control the blood glucose level, you consider hypoglycemic agents like metformin, glibenclamide, and insulin. On diabetic patients on oral medication who become pregnant can be maintained on their oral medication if sugar control is satisfactory. And that's fasting glucose levels between 4 to 6 millimoles per liter, and 2-hour postprandial glucose between 4 to 7 millimoles per liter, and glycated hemoglobin as HbA1c less than 6.5%. Indications for oral antidiabetic agents use. So gestational diabetes who fail to achieve satisfactory control with diet and exercise alone, that's FBC more than 6.1 millimoles per liter, and poor compliance to insulin, for example poor administration skills, also poor glycemic self monitoring, and insulin therapy poses financial burden or is not readily available. Absolute indications for insulin use. Significant diabetic related morbidity exists, as for example nephropathy, retinopathy, and neuropathy, and persistently high hemoglobin, that's H1C, and persistent ketonuria, significant obstetric morbidities, for example fetal macrosomia, polyhydramnios, and IEGR. Also during antenatal corticosteroid therapy with expected deterioration of glycemic control, and poor glycemic control with oral anti-diabetic agents. So in this these are absolute indications for insulin use. So normally metformin oral 500 milligrams 8 to 12 hourly is given with a maximum dose of 2 grams per day, or glibenclamide oral 2.5 to 5 milligrams 12 to 24 hourly. So increase dose by 5 milligrams if necessary until a maximum dose of 50 milligrams per day. And metformin can be given as monotherapy or in combination with insulin or sulfonylurea. The use of sulfonylureas, for example glibenclamide in pregnancy, should generally be avoided because of the risk of neonatal hypoglycemia. However, glibenclamide can be used in the second and third trimester in women with gestational diabetes. Or you give insulin You start with small doses. There's a total daily dose of 6 to 10 units of NPH insulin or premised insulin, which has 30% of regular and 70% of NPH insulin subcutaneously. You give approximately 2/3 of the total daily dose before breakfast and 1/3 before dinner. You adjust the insulin doses before breakfast or dinner by plus or minus 2 units according to results of blood glucose test. And also you monitor insulin therapy with 2 to 4 weekly FBS and 2-hour postprandial blood glucose where possible up to 34 weeks, and then weekly till delivery. We keep fasting glucose levels between 4 to 6 millimoles per liter, and 2-hour postprandial glucose between 4 to 7 millimoles per liter. It is often achievable on an outpatient basis. However, some patients will need to be admitted to hospital for short periods to ensure good glycemic control. Insulin requirements during labor should be given according to a sliding scale. Insulin requirements during cesarean section and other operative procedures using a sliding scale or glucose potassium insulin infusion or GKI should be discussed with the anesthetist. So referral criteria: you refer to the hospital for specialist care for the convenience of patients, shared care between specialist and the medical officer, and this may be appropriate. So for the convenience of the patients, shared care between a specialist and a medical officer may be appropriate.